why should we choose point-of-care EEG? What's the reason for it? What is the process that says, hey, I wanted to choose a point-of-care EEG over a standard conventional EEG? So some of the similar reasons that we talked about as limitations for the conventional EEG are the reasons for point-of-care EEG. So again, time to place seems like it would be shorter, given what we saw in the video also. In general, the cost is less because it has less infrastructure needed. There is, of course, disposable devices, but it doesn't need time for a tech. It doesn't need dedicated EEG machines. So the infrastructure is also smaller. And the idea is potentially more rapid clinical management. If we're able to get data from that point-of-care EEG faster, we're able to treat them more accurately and more quickly. So this seems like all very good things, but is this actually true? So there are some studies that we looked at to try to figure out, is this true that these reasons are accurate to have point-of-care EEG as a technology? So for time to place, there's a review article that went through a bunch of different sites that had point-of-care EEG time to start monitoring versus conventional EEG. And so the left numbers are all the point-of-care EEG start to monitor, and the right ones are all the conventional EEG. You can see that just in general, while the numbers are varied between different sites, the time to place to start monitoring is less on the point-of-care EEG side versus the conventional EEG side. So that's a important thing to say, hey, well, if it's 5 minutes versus 239 minutes, for example, and the patient has seizures, it's theoretically should make a huge difference in their care if we're able to see seizures. We'll give some numbers on that as well, if that's also an important part. Next, the cost. So cost savings, while there are, of course, costs associated with new technologies, there was a cohort study in 2023 that looked at these patients to look at point-of-care EEG to see if it would help with cost. And in general, with that one study, they showed almost 11 less transfers per year. So that was a significant number of less transfers. And by transfers, these transfers, what they were mentioning were people who were needing to transfer the patient to a more tertiary hospital for conventional EEG, and they were able to not transfer them with point-of-care EEG at their hospital site. So they were able to reduce the costs of the loss of these in transfer, as well as save money annually. And then length of stay is also an important part of cost. And the multiple studies that show that there is a decrease in length of stay. 7.4 to 6.1 was the averages, and in general on the ICU side, at least half a day less length of stay, depending on the scenario. So there was a decrease in the length of stay for them using point-of-care EEG. And then, as I mentioned before, does monitoring quickly help with management? So sometimes it does. You would anticipate that if you are monitoring more rapidly, quicker to see the abnormalities if they're there, you'd be able to treat faster. And that is what they saw in this study, that they showed treatment escalation occurred more frequently when there was abnormalities on the rapid EEG or point-of-care EEG versus when they didn't see epileptiform activity on the EEG. And similarly, they frequently or more frequently avoided treatment escalation when there's suspicion of seizures based on the EEG. So they were able to see potentially that there wasn't seizures in a suspected case of seizures, and they didn't need to escalate further, potentially leading to more length of stay, et cetera.